Okay, let's talk about kids with asthma, right? Because this is something that we commonly see with kids. Because it's one of those disorders that as they grow and develop, they can actually grow out of, right? So a lot of the signs and symptoms that happen with asthma is because of their immature systems. So once they hit like 10, 11-ish, they've kind of, their systems are more like that of an adult, and we see that a lot of them who are diagnosed with asthma actually move out of those signs and symptoms, and they no longer need the interventions that we put in place with them, right? But, so, with asthma, you've got a kid who comes in, we'll say to the ER, with signs and symptoms. What are you gonna see?
Wheezing.
Okay, wheezing. Maybe low sats. When you're asking them questions, are they gonna be able to talk in full sentences? No, right? So all of those things play into what we call a respiratory severity score that we use for scoring how bad their asthma exacerbation is, right? And so this asthma pathway kind of follows that respiratory severity score, right? So they come in and you've initiated their asthma power plan, right? You notify the ED that there's an asthma patient, you start your bronchodilators, because there's only one med that really matters when it comes to asthma, and it's what? Albuterol, absolutely, right? It is your only rescue med for asthma, right? Albuterol, okay? So you start those, you assess them, you score them, and treat them based on that score, okay? So following your pathway, you got their pulse ox is less than 90 while awake, 88 while asleep. If it's yes, you're going to start oxygen therapy. If it's no, have they been given a steroid and how much, right? So you're just going to follow the pathway. So if they no, you're going to get your provider's order for your steroid treatment. Yes, they've had their max dose, right? Because that's how much. So if they haven't had their max dose, can we give them more to get to their max dose? Absolutely, right? So albuterol first, followed by the steroid, okay? Much like with croup, we want the epi first and then followed by the steroid, okay? The steroid isn't going to act as fast, so we need those rapid acting meds first, okay? So your RSS score, if they score between 8 and 15, they are a severe asthma patient, okay? Meaning we're gonna start them on a continuous albuterol, and this is then where we add that ipratropium, okay? So based on your score, whether they're mild, moderate, or severe, will determine your interventions. Are they gonna be placed on a continuous albuterol? Are we just gonna do like a Q1 albuterol, or are we gonna do like Q4 albuterol with frequent assessments, right? So you're just gonna kind of follow that plan, okay? And then you're gonna reassess after your interventions and see how they do, okay? In our severe category, you're gonna give them that continuous albuterol, activate their power plan, or with their power plan order, and then add ipratropium with their first dose. And then if there's no improvement after the first hour, we're gonna give them another continuous albuterol. We're gonna start IV fluids. We're also going to add in MAG, because MAG does what? It relaxes their muscles, right? So we want them to start relaxing, so we're gonna give them that. And then we're gonna document Q1 hour, right? So did those interventions work? If not, are they going to need another continuous albuterol, okay? If they've had 2 continuous albuterols and they need a third one, they will then go to the PICU, because they are likely going to need to be what? I love how everyone's miming what they need. They might need to be intubated, right?
I can't think of the word.
I love it. I know what you mean, and yes, you are right, absolutely. That, yes, they need that. They need to be intubated, right? So if they've had multiple continuous, they're gonna go to the PICU and with a likelihood of being intubated, right? asthma is a really crazy thing. Like, it can happen really quick, and the interventions will differ based on how bad they are. Okay? I had a kiddo when I was working in a rural hospital in Colorado. I was the only Peds nurse on. Every other nurse in the facility had no Peds background. I was dealing with a kid who had bronchiolitis, who was deteriorating really fast. I lost the IV. I was trying to put an IV in with like no Peds help, so nobody had any idea what I needed. I was trying to explain to them, like essentially teach them while I'm trying to save this kid. And I had oxygen on him. I had a second oxygen source. I had a adult bag valve mask on him as well, trying to give more oxygen to him, and I still couldn't get his sats up above 85%. And I was telling my coworkers, I was like, I need this, I need that, and telling them where to try to find it in the treatment room, and they were all coming back, I don't know what you're talking about, I can't find it. I had to keep leaving the kid to go get what I needed and leave someone who doesn't deal with kids with them, and until the flight crew got there, because I was trying to stabilize enough to fly him out to the children's hospital from where we were at the rural facility. I was going through all of that, and as the helicopter was taking off, the doc calls and was like, I'm going to admit a child with an asthma exacerbation with a history of intubation, and I was like, you better call that helicopter back. And he's like, what? I'm like, I'm not taking that kid here. Like, if you're telling me that with every asthma exacerbation he gets intubated, we don't have a PICU here. Why are you admitting here? Call the helicopter back and send that kid as well, all right? Know your limits with respiratory, because things can go downhill so fast, okay? Know what you're looking for, know your interventions, and know what your resources are and what pathway you're supposed to follow, right? Because this is like what you're gonna follow to the T, right? We rarely deviate from that, okay? Then once you kind of get through like the initial stages of what's going on, it also has their disposition, right? Where are they gonna go, and what are we gonna do for them next, right? So as far as PICU admission criteria, so if they've got increased hypoxia despite their O2, their RSS score is above 12 and not stable on high flow nasal cannula, they need BiPAP, CPAP, or physician discretion, right? If the physician doesn't feel like this is a kid who's safe for like the med-surg floor, they'll go to the PICU, right? If we're going to go inpatient to just like an OBS or a med-surg unit, we've also got that on here. So we're keeping their stats at or above 90. Their RSS is like 7, but definitely less than 12. And then if we're gonna discharge them, their RSS is in this mild range, right? 5 to 7. So we've given them their albuterol, they've recovered, they look good, they're able to eat and drink, and we're able to keep their stats, okay? So when it comes to asthma, do you think a lot of education is needed for these families and these kiddos? Yes, right? What does that education look like?
What inhalers to use, when to use them, what
Okay.
to look out for, things to avoid if it's like allergy driven.
Yeah, absolutely, right? Because a lot of kids who have asthma, there's this like triangle of disease processes that are connected. So if they have asthma, it's likely to have allergies. If they have both of those, it's likely they have eczema, or a combination of the three, right? Allergy, eczema, and allergies, eczema, and asthma kind of go all together, right? If they have got one, they likely have another, or they have all three, okay? So yes, so education is huge, right? So what inhalers to use, when to use them, right? So we've got ones that are controller meds. So our controller meds are what? So Montelukast is like an oral medication. Steroid, yeah. So their controller med is they usually take it twice a day, once in the morning, once at night, every day, regardless of whether or not they have symptoms, right? They are controlling their asthma through those, through that inhaler. Other things like maybe Zyrtec or Claritin if they've got allergies, Montelukast or Singulair is another one that they can be on to help control their symptoms, right? Control their inflammation. With that though, it is also important to educate the parents on adverse effects of those combinations of meds in general. What is one thing that you might see in kids who are on Montelukast? Increased aggression. Yes. Montelukast or Singulair can cause increased aggression in children, especially in combination with Zyrtec. Right? Lucas, my son, had reactive airway. So on this picture here, you can see it says asthma and RAD. RAD is reactive airway disease. So we don't always give, we do not give the diagnosis of asthma until after age like 6 to 7. 6, 7. I can't help it. It's just there.
It's really just happening that way.
Just commit to one of them, please.
6, 7.
Because I'll even say 6 now.
Because beyond that, they start to grow out of those symptoms, and we might not see it as much, or it goes away completely about that age, right? Some of them will take a little bit longer until about 10, but around 6 to 7 is when we'll see it kind of go away. So asthma is a lifelong thing. If you give them the diagnosis, it sticks with them. But if you call it reactive airway, in that they just have it with like an upper airway infection or something like that, it's not a lifelong diagnosis. Like they don't have to put it as like a disease process that like they've got, right? Okay. Where was I going with that? So controlling. With the Singulair, the Zyrtec, they have that increased aggression. So Lucas started having some reactive airway issues around age 3. I was at work, I came home, he had a friend over, we were watching one of our friend's kids, and I walk into the living room and Lucas is standing there and every accessory muscle he has is retracting. And I look at Gabe and I was like, how long has he been like that? He's like, why? I'm like, because he's in respiratory distress. And he's like, but he's running around and playing. I'm like, yeah, he's 3, but he's in respiratory distress. Like, you didn't notice that this was a problem? And he's like, no. And I was like, okay, I'm gonna take him to urgent care. You're gonna stay here with this kid, and then we'll go from there. That ended up being a 3-day hospital stay, because Lucas's oxygen wouldn't come up above 90 regardless of the interventions that they were doing. And I'm like, seriously? Like, he's like, I'm not the nurse. I'm like, okay, but you could at least recognize when our child is in trouble, right? And can't breathe. And he's like, but he was running around. And I was like, okay, so? Like, that's a problem. He's running around on low oxygen. I'm like, I don't even know how he was doing that. So we took him to urgent care, and they were going to give him the albuterol nebulizer, and they went to like hold it on his face, and he yelled at the nurse, and he's like, I'll do it myself. He's very independent. He likes doing things for himself. Yeah. And so from that, then so he already had allergies, so he was on Zyrtec. And then because of the reactive airway, they added in Singulair or Montelukast. And the increased aggression that we saw was like a teen going through puberty on steroids, but at like age 3. Like, it was awful. Like, the screaming, the yelling, the slamming doors, like, everything, it was awful. We did that for 3 years until I was like, I can't do this anymore. And so we weaned him off of his Singulair, and almost within a month saw a complete behavioral change, right? So making sure your parents are aware that if this is a new medication regimen for them, like if this is especially a new diagnosis for them, and they're gonna be on this regimen, to look out for those things, right? Because if that occurs, there are some med changes that we can do to make it a little less severe. They might still need to be on the montelukast, or we can take that away. They can just be on like the steroid. But the allergy aspect of it, Zyrtec works much better for like animal and pet allergies, where Claritin works much better for outdoor allergies. We had both a cat and a dog that when he was allergy tested was off the charts allergic to, but they came first, so we opted to medicate our child. They are family as well, right? So so he got medicated. But over time, he's gotten used to them, and they don't bother him as much. However, now in the last year, we have lost both, so we are currently pet-free until 3 weeks. We're getting some new kittens that he doesn't know about yet. Cool. Good with asthma?
Yeah.
Okay. The other thing that they will have an asthma action plan. The asthma action plan. Have you seen an asthma action plan? Yes?
First, yes.
Some of you?
First.
For school, they should also have one at home, right? So,
The school assignment, which I did, you should know.
so yes, so if you've done your school assignment, you should know that. Okay, so your asthma action plan, okay, has their information at the top, what the different zones mean. So green means good, they're just using their preventative meds, right? So if they're on a controller inhaler, they're using that daily, usually twice a day. Yellow is a caution zone, so they might have to add their quick relief medication, being what? Albuterol, good. And red means danger zone, get help from the doctor, right? So in each of those zones, we're gonna have their medication, how much and how often they're taking it, right? So if their breathing is good, they have no cough or wheeze, they're sleeping through the night, they can work and play, no problem, and they've used their peak flow meter, so we know when they're healthy, we got those numbers, so we know what their peak flow is. So when they inhale and blow out, we know how much their lungs are capable of bringing in and putting out, right? So that's where we get our peak flow numbers. So if they've got no signs and symptoms, everything's good, this is just a control zone, right? Now if they move into having signs of maybe a cold, so they're starting to have like a runny, stuffy nose, or they're waking up frequently at night, they feel kind of maybe tight in their chest. This is where not only are they still taking these meds, but then we're gonna add in, what do you need to take on an as-needed basis when these things start showing up, right? So do you need to take your albuterol inhaler? If you weren't taking your allergy meds like you needed to, now do you need to start taking them daily, right? And then red zone, so they've moved from here to here, this has gotten worse, so now they're here, and they've used their quick relief inhaler with no results. So they've used it, they still feel like they can't breathe, their wheeze hasn't gone away. We need them to get to the doctor, right? We need them to either go to urgent care or to the ER, okay? So they will have a copy of this at home. They will also have a copy of this at the school, so the school knows what to do when they're having signs and symptoms while they're at school. Okay, or daycare, or wherever they're at, wherever they're gonna spend a majority of time or a good amount of time, we want them to have this and the medications on hand, right? So, so the school nurse needs to know this, right? They will have the medications, and the child needs to know when to go to the nurse, right? Cool? Cystic fibrosis is our next one. What do you know about cystic fibrosis?
Genetic.
It is genetic. What else do you know about it? What is their life expectancy? What? Late 30s, early 40s. With modern medicine, it has gotten much better. Back when they first, like when this first started kind of showing up and they knew what it was, their life expectancy wasn't much into their late teens, early 20s, right? So we've pretty much like doubled, sometimes tripled their life expectancy. What else do you know about it?
A lot of like secretions, so reduces like their O2 exchange.
Okay. Are the secretions just specific to the respiratory system? No. You were right the first time. No. It is not just a respiratory system. So when we think about cystic fibrosis, we think about their it being a lung disorder, right? Because it is a respiratory thing, right? However, any system in the body that produces mucus is affected by cystic fibrosis, right? So your sinuses produce mucus, yes? So we're gonna see that they present with what? Lots of drainage. Maybe they are being treated for frequent like sinus infections, right? Because all of that mucus that's there is a breeding ground for what? Bacteria, right? Infection, okay? It's like sitting in a petri dish, okay? In our lungs, we get thick, sticky mucus buildup, right? Which leads to what? Pneumonia, infection, right? Absolutely, okay? Our skin, in those sweat glands, produces a salty sweat. So one of our diagnoses for cystic fibrosis is what? The chloride test, right? We now can send their sweat sample to the lab, right? Guess how we used to test for it before we had the lab? You licked your patients, and if they tasted salty, you knew they had cystic fibrosis, right? That's not as bad as nurses used to taste the urine to taste if it was sweet to diagnose diabetes, right? That is exactly what they used to do. Aren't you glad we've come a long way in diagnostic testing? Because if I had to taste anyone's urine or lick their skin, I think I would crawl out of my skin. I would choose a different career altogether if I had to lick my patient and taste their urine. Right? Absolutely. Absolutely. There is a show on Netflix, I think, called The Midwife, or something about the midwife. And there's an episode where one of the nuns or the nurses is diagnosed with cystic fibrosis, and she kisses the child and was like, yes, she's sweaty, right, or he's sweaty, or something like that. And so that's how they used to diagnose cystic fibrosis. Okay. Your liver. What happens when you have blocked biliary ducts? Yeah, right? So all of like your liver function tests are gonna go up. All of your lab tests, your liver's not functioning like it should. Waste products that are getting filtered aren't being released into the body to be excreted, right? They're just building up there. Same thing with your pancreas. What happens when you have blocked pancreatic ducts?
Your insulin.
Yeah, you got issues with your insulin and sugar, right? Your digestive enzymes aren't being released to help digest your food. What happens when your intestines are full of mucus? Okay, retention of fecal. Decreased absorption, right? You've got all that mucus there that's blocking the ability to have adequate nutrient absorption. Okay? Your reproductive organs, what happens when there's a lot of mucus there? Reproductive problems, infertility, right? Okay?
My name is Ashley Bricker, and this is my son Johnny, and this is cystic fibrosis our way. Johnny is 5 months old and has been treated here at CHOP for CF since he was 5 days old. Every day, Johnny receives enzymes to help him digest and absorb his food. He also gets chest PT twice a day, and we try to make it as normal in our daily routine as possible. And this is how we do his enzymes and chest PT. To give Johnny his enzymes, we put them on a spoon with a little applesauce. He receives them before every bottle or any time he eats. Enzymes have no taste at all, just make sure you don't crush them or chew them. I always wash my hands and remove any rings or bracelets on the hand that I use the percussor with before I start his chest PT. Johnny's chest PT is done in 2-minute increments on 12 positions on his body. We try to make Johnny's chest PT fun. We sing fun songs, we do fun rhyming games, and we know it takes an entire Disney show to do all of his chest PT. I never do percussion on his bare skin, and as he gets older, we'll use larger percussion cups, or we can use cupped hands. And if he needs it, throughout or after his chest PT, we can suction his nose to make sure we get everything out. Everything I do on the one side, I repeat on the other. So that is how enzymes and chest PT are done. Johnny is obviously too young for us to know what he wants to be when he grows up, but we already think he's a superhero. He's the toughest little kid we know.
Isn't he cute?
My name is John Palmer, and this is cystic fibrosis mine. I'm 15 years old and have been treated for CF at Children's Hospital for as long as I can remember. But it doesn't get in my way. I just make it part of my day. When I grow up, I'll play basketball for the Cleveland Cavaliers. It's an exciting team. Maybe play with Kyrie Irving. He's number 2 on the team. If I want to play basketball professionally, I need to make sure I do my therapy, my nebulizer, and my huff coughs every day. 2 times a day when I'm healthy, and up to 4 times a day when I'm sick. First, I take 2 puffs of the inhaler. This opens up my airway. Then I hook the machine up. I put the vest on the clamp and then I buckle it. Then I make sure the holes are inside the vest. After that, you have to put your tubes in. Then I put the medicine in the nebulizer. Next, I turn the nebulizer and vest on for 20 minutes. My pressure is 7, and my frequency is 11. That's how fast it goes. But every case has a different setting. Just make sure you know what your doctor told you to do. Sometimes the treatment takes longer if there's more medicine to do. After 10 minutes, I do my huff calls. vests. I get to play with my computer, play with my phone, or do anything I want for the time being until my lesson is done. After 10 more minutes, I'll have to do another huff cough. After I'm done, I take my Flovent and my nasal spray. If any mucus comes up, then I spit it out, and then I'm done. Then I get to have fun, play ball.
What are some interventions you saw in those 2 videos?
Chest physiotherapy, whether it's the chest or the
Okay, so the chest physiotherapy, the Flovent. Okay, the huff coughing. Yep, so what's the huff coughing do? It does. So it's a forced cough to help bring up that mucus, that vest or that percussion has broken up, so that we can try to expel that mucus. Okay. What else did you see?
See that the mother in this case was involved on the therapy.
Okay.
And for the older one, he knew what to do. And
Yes.
it's not that the physical therapy did. They learn how to do it because at the end of the day it's a line.
Yeah, so the difference in those developmental stages between the infant and our adolescent, right? Mom was involved in the younger kid, but our adolescent was able to do it himself, right? That autonomy piece, right? He's got this disease process, he's gonna be living with it, so should we be educating him on how to do things?
Yeah.
Absolutely, right? And that's what they were doing. He was also, did you see he was also in the treatment room?
Yeah.
Did you see all the things that were in there? Yeah, so bright, colorful, lots of toys, right? That's what our, actually that was the playroom, not the treatment room, sorry, the playroom. So it's got like all those bright toys, developmentally, like different levels of things for kids to play with. Okay. What other interventions did you see? The enzyme. What's the enzyme for?
The pancreatic enzyme.
The pancreatic enzymes, which help with digestion, right? So we just talked about how mucus affects digestion and absorption, right? And so if the pancreas isn't getting out those digestive enzymes, how are they gonna break down their food? Well, we can give them those enzymes, right? So we talked about last week how we dose most medications based on their weight, right? How do you base your dosing of enzymes for those pancreatic enzymes?
Meals,
Huh?
because it says she gave it before each bottle of each meal.
So that's what you should give them, right? So they will be given with meals because we want the enzymes when they're getting their food, right, to break it down and be most efficient. But how do we know we're giving enough or too much? What? Their bowel movement. What about their bowel movement?
If you give too much, it might be a little runny.
Not necessarily runny. It won't have a lot of fat in it, like, yes, right? And so if we're not giving enough, you'll see fatty streaks, right, in their stool. So do adolescents love to talk to us about their bowel movements?
No.
No. Not at all, right? They don't like to talk about those things. But our kids with cystic fibrosis, do we need them to talk about their bowel movements? Absolutely, right? We need to make sure that they're dosing their enzymes appropriately so that they have the most opportunity to absorb those nutrients as they can, right? For kiddos with cystic fibrosis, what other interventions do we want to put in place? some inhalers, some mucus expectorants, right? What about their isolation protocol? Okay, not being around sick people. Who else do we not want them around?
Other patients with cystic fibrosis.
Other patients with cystic fibrosis. Why? They could pass deadly bacteria back and forth to each other, right? So ideally, those with cystic fibrosis should not be any closer than how many feet apart? 6 feet apart. Is there a movie?
Yeah.
6, 7. 6 to 7 feet apart. 6 feet apart, right? But a lot of that is because they each contain their own bacterial flora, just like we all do, right? We all have our own bacterial flora. However, their mucus that's just hanging out in their lungs is a lovely breeding ground for that said bacteria, right? And when it gets passed to another patient who has a compromised system, is bacteria an opportunistic infection? Yes, right? So it will take hold.
Well, we're not compromised.
So, their family unit is not such a big concern because they're all living in the same household, so likely they have a good, like, they all have somewhat of the same flora. But yes, we ideally want them to be very careful around everybody, but specifically those with cystic fibrosis. Because, like, yeah, we have our own flora, but we don't always, like, we don't have mucus just, like, hanging out in there, like, breeding like they do with cystic fibrosis. Okay. What else might you see that they need? What if they've got too much mucus in their lungs? Who are they going to be followed by? Pulmonologist, right? And one of the interventions they can do is what we call lung wash. So they'll go in and under sedation, they'll go in and they'll wash out the lungs and pull all of that mucus out, right? Okay. Bronchoscopy is the procedure. Yep, absolutely. Right? They've got all of this mucus, and we've taught you up to this point that if someone has mucus, we just want them to what? Cough it out, drink a lot of fluid, right? You know, the more fluid you drink, the better it's going to be because you're going to break up that mucus. Is that going to help patients with cystic fibrosis? No, right? This is not they don't have enough hydration, right? It is just their disease process overall causing all of that mucus. Okay? Feel pretty good with that? Okay. So that is respiratory. Okay. Doesn't seem as daunting as all the information from last week, right? Right. Seems pretty straightforward. Okay. All right. So now we are going to do an activity. Okay. So you should all see it. It's going to ask you to select a little emoticon thingy. And we even have a Halloween themed one. I'm so excited. Right? So we're gonna go through some questions that I've put together that are in a very similar format of what you might see on the exam. Okay? Some interesting little characters, huh? So when we do start, the questions will be presented. You only have 30 seconds to answer. I know, unfortunately, I cannot change that. Obviously, you have a little bit more time on an exam, right? But you will see where everyone is scoring, so get competitive, right? It's okay. This is a fun activity. Okay. Let's see. Should have 19. Someone not connected. There's 19. Oh, there is now. Nice. Okay, everybody ready?
Yeah, ready and yummy.
Can't read that fast.
Oh, Jesus, a lot. You can only pick one answer, that's. Once you click it, you're locked in.
Yes, there's no change in your answer.
Oh, I didn't even know
I didn't even get to read.
I told you to read fast.
I kinda need to read it.
Hold on.
Yeah, lock in.
Hold on.
No.
Hold on, I'm gonna restart it because it's supposed to stop in between. Sorry.
It's good, we got it wrong.
So you'll have a second chance at answering that first one correctly.
Wait, how did you get a rain jacket? Me?
You got a rain jacket? Oh, yeah, it did get rain.
I got kicked out.
How'd you get a draft?
You can continue scrolling through, like, I'm.
All right, there we go. Okay, cool. So your answer here is B, right? Fluticasone must be used regularly twice daily to be effective in preventing asthma. Okay? So this is that steroid inhaler that you'll use as a controller inhaler. And they will often take it twice a day, once in the morning, once at night. So A, right? So we talked about your allergy triggers. So if the kid is allergic to animals, they often will have asthma as well, right? Or if they have allergies, they're often going to have asthma. So animals is probably one of their triggers. Right? So anytime they're over there, they have an asthma attack. Yep, that's because you went right near your trigger.
So weird.
Right? That's your asthma.
Yeah.
albuterol. This is the only medication used with an acute episode of bronchospasm, right? That is our rescue med, albuterol. Okay. The other, like the ipratropium will be added in later, but they're gonna get that albuterol first.
Remember cold?
No, I read
That's all. Cold air.
Okay? So it's caused by the viral infection that affects the airway, right? The symptoms are not a result of inhaling cold air during outdoor play. We want them to inhale the cold air during outside time. Okay? When they're having that. And it's not a bacterial infection in the lungs. Remember, croup affects the upper airway. Okay. So, humidified oxygen doesn't prevent oxygen toxicity, right? The only thing that's going to prevent that is not using too much oxygen, okay? Humidified oxygen does make it more comfortable for them to breathe. The humidified oxygen does not improve their oxygen saturation more effectively, right? The only thing that's going to improve their oxygen saturation more effectively is opening their airways, right? Either getting rid of the mucus or getting rid of the inflammation that's causing that decrease. And then humidified oxygen helps kill the virus causing the bronchiolitis. Not at all.
Is the quiz gonna be like this?
Maybe.
I went with the ones with the bold titles.
Oh my gosh,
Okay, so,
I can't even read them.
I know, it does go too fast. I wish I could change the tab on it, but, so this is where taking some of the developmental, components of your assessment will play into identifying, who's most at risk, right? So you're rounding on your patient and you're prioritizing based on, their needs, right? So you've got Matthew, who's at 4, who's alert and oriented on 3 liters with a nasal cannula, and his stats are 92. Is anything in that concerning? No. For kids, we're okay not having 95 and above. So like for your adults, it will have in there like we want them 95 and above, right? For kids, we're good 90 and above while they're awake, and 88 and above while they're asleep. Okay? So Matthew, there's nothing concerning. Everything's good, right? He's on oxygen and he's setting at 92%, which is good for a kid. Michael, who's 12, appears to be sleeping in a prone position with a heart rate of 78 and a SAT of 96. Is that okay?
He is not.
Yeah. Who cares what position he's sleeping in as long as his stats are good and his heart rate's good, right? Is set heart rate of 78 for a 12-year-old good?
Yeah.
Yeah, absolutely, totally fine.
You should.
Sarah, who's 5, is on 3 liters of oxygen. She's sitting upright in bed with a sat of 98.
Great.
She's good. Tamika, who's 2, is sitting up in bed, has a heart rate of 150, a respiratory rate of 38, who is quietly watching TV. Why?
Them 2-year-olds will never be quiet.
Okay,
Heart rate is fast,
70
she's
to
breathing
120 for
fast.
your heart rate. The respiratory rate is a little fast.
And
Should a 2-year-old just be sitting quietly watching TV in bed? No, they are up, they are active, right? So for a child who normally should be up and active and moving around and have lots of energy, for them to just sit quietly watching TV, you know something's wrong, right? But also those vital signs are out of the normal range, okay?
Wait, I can only cook 2 of those? Maybe it cuts you off.
Okay. So, you've got a 3-year-old who has been diagnosed with acute epiglottitis. What nursing interventions would you do? What are your priorities? Why do we not want to attempt to visualize the oropharynx? Okay. So they've been diagnosed with acute epiglottitis, right? If we try to pry their mouth open and look in there, what are they likely to do? They're gonna get agitated, they might scream, they might cry, right? Is that going to increase the inflammation in the epiglottitis? Yes. So we do not want, so with a already suspected diagnosis of acute epiglottitis, we know that that's what's going on. We're not gonna look in there, right? Do we want to allow them to maintain a position of comfort? Yeah, because what's gonna happen if you try to put them in a position that they're not comfortable in? They're gonna cry, they're gonna get agitated, they're gonna squirm and wiggle around and get to where they want to be comfortable, right? Are you gonna monitor their oxygen saturations? Yes. Do we need to obtain a throat culture as ordered?
No, because it's viral.
Well, cause then they could get, go to the surgery, cause they gonna hit something.
We don't wanna put anything in there and agitate that as well, right? Just like we don't wanna open it up and inspect in there, we're not gonna shove a swab in there to swirl it around either, right? We don't wanna already agitate it, the area, okay?
Nothing in control. Yeah. For you, that's good.
Yes. So. Okay. So hyperalbuminemia is not a finding that you're gonna find in cystic fibrosis. Clubbed fingers could happen, but is it a sign that you're gonna see with a new full-term infant who just was admitted to the NICU?
No.
No. Clubbed fingers happen as a result of what?
Years and years and years.
Chronic hypoxemia over an extended period of time, right? So our older kiddos might have this, but our younger kiddos are not, because where are they getting their oxygen from? Like this baby who was just born. where were they getting their oxygen from prior to being born? From the mother, right? Who had adequate oxygenation, right? So there should not be any club fingers yet. That will happen later, okay? Jaundice does not happen in cystic fibrosis, but a meconium ileus will. So there is a delayed meconium passage with cystic fibrosis. So that is one of the hallmark signs of cystic fibrosis, is that they haven't passed their meconium within a couple days of birth. Okay? So, stridor happens where? Upper airway. Your crackles, rhonchi, and wheezing happen lower, right? So, make sure you're distinguishing between upper and lower airway sounds, okay? Okay, so you've got a kiddo who's got a stat of 78 with a respiratory rate of 40. Is just maintaining the airway and continued assessment going to fix that problem? Is 100% oxygen in pulse ox going to fix that problem? Not if you lose that airway, right? 100% oxygen in a position of comfort, that's not gonna fix it, right? But if we maintain that airway and deliver 100% oxygen via the mask, is that going to fix the problem? Yes. Okay. What type of question is this?
Cystic fibrosis question.
It's a medication administration question. Do you need to know what that med is to answer the question?
Yeah.
No, you do not, right? So let's go through it and talk about why you do not need to know about what that medication is to answer the question. So, can you crush a sustained release medication so it's easier to swallow?
And you can't crush any.
You cannot crush any sustained release, right? Should I give theophylline only when my child is having asthma symptoms? No, because we know that the only rescue med is albuterol. If I miss a dose, can I double the dose next time? Do we ever just double up doses of any medication? No.
They seem to do that with birth control.
Well, okay, there is that. Most medications we don't just double up, right? giving theophylline with food will prevent stomach upset. We oftentimes will tell them to take their meds with food, right? Because it could prevent stomach upset. So, knowing the other ones are a no, you can deduce that the correct answer is that first one, right? Giving my child the theophylline with food will prevent the stomach upset, right? Now, there are, again, some meds that we will talk about that you cannot give with food, but this is more of a medication administration question, right? So we've already eliminated, you can't crush the sustained release. We know that the only rescue med is albuterol, so that one doesn't make sense. And we don't double up doses. So if you eliminate the other ones, there's only one left that actually makes sense, right? Okay, so keep that in mind as you're going through. Can you eliminate these other ones because we know that we just can't do that, right? Okay. So we want a high calorie diet, right? So if they've got malabsorption, we want to increase the calories that they're taking in because that increases the chance of how much of it they're actually going to absorb, right? As it's passing through. So what food is actually high in calories? Or what type of foods? Your junk food, your food that's typically not good for you, right? Food that's high in fat, because there's a lot of calories in fat. So we want them to take in like a high calorie diet, one that's rich in kind of fats, and it will increase their potential for absorbing more than they would get. So, Montelukast just does not do A. And there's no more than that. For B, Montelukast increases mucus secretions and bronchodilation. Do we want an increase in mucus secretions? No. We want less, right? Montelukast promotes bronchodilation of overly dilated airways. Why do we want overly dilated airways even more dilated? That does not make sense, right? But the goal of a controller med, which Montelukast is to decrease what? Inflammation, right? We want to keep that inflammation at bay. Okay.
So you do your acute one, which is like your albuterol, and then you kind of like sustain the inflammation with your Montelukast and the whatever one.
So you will rarely see theophylline.
Okay.
Right, that is a med that we don't use very often. But your controller medications will be like your fluticasone, so your steroid inhaler that you're going to take twice a day, right? Montelukast, they might be on like their allergy meds, which are keeping their allergy response at bay, right? So you're kind of hitting it from a couple of different directions, but ideally we want those meds are going to help decrease inflammation, right? And that immune response that they're going to have that's going to increase like mucus production and inflammation. So they will every day will be taking their controller meds, they will only need albuterol if they have like a breakthrough exacerbation. Yeah. You can remember these by ADEC. A-D-E-K. ADEC. Okay? The other ones are not fat salt. So it's only suspected epiglottitis. What else can present like epiglottitis? Foreign body, right? And so how are we gonna know?
Gotta confirm it.
We gotta confirm it. We gotta get that X-ray, right? So just why are we gonna initiate them on IV antibiotics if we don't know what it is, right? That's not just a thing that we do. And so we also don't need to just throw them on fluids or place them on droplet precautions either, right? We need to confirm that, is it epiglottitis or is there a foreign body? Good job. By now, you should know that albuterol is like the answer, right? Albuterol. 6 out of 7 times it's gonna be albuterol.
7 for Alex.
What should the nurse? 6.5.
Okay. Okay. Yes.
He's overused it.
Yes, absolutely, right? So let's talk about the other ones first. The 6-year-old with intermittent asthma who awoke with a cough for the last 8 nights, right? So you're in the clinic now, and that's what they're presenting with, right? They awoke at night with a cough. Do they have a cough right now? Is it night right now? Right? So there's nothing in that suggests that you need to see that child first, right? A 14-year-old with moderate persistent asthma whose peak flows have dropped to 87% of the personal best. So if you've gone through and you've done like your asthma action plan and you're looking at like peak flow stuff, you'll know that 87% is still good. That's still in the green zone, right? They can drop to a little bit lower before we're concerned about them going into the yellow zone, okay? The 70-year-old with exercise-induced asthma who has been short of breath while playing soccer. Well, are they playing soccer right now in the clinic? No, I would hope not, right? But your 12-year-old who has used all of their prescribed rescue inhaler in the last 5 days, is that concerning?
Yeah.
Yes, absolutely, right? They should only have to use it like 1 or 2 times, like in a week, right? If they're using all of it, which is a lot in 5 days, they are not being controlled, right? There's something going on, okay? So that is the child being used first.
No, this is too long.
It's not, what was site, what does the patient get for literally anything SSRI? Yeah. The respiratory patient started with albuterol.
Never was something.
It's actually like albuterol every time.
Okay, so you assess that 12-year-old, right? So that 12-year-old that we said needed help, and find that the child has a respiratory rate of 40, intercostal retractions, a high-pitched inspiratory, expiratory wheeze. Which of the medications prescribed are you going to give first? Albuterol, right? He's having an exacerbation, so you're going to give albuterol. That is our rescue, okay?
Yep, that's our first.
So we know that albuterol has a expected side effect of what? Tachycardia and shakiness, right? So hand tremors, generalized shakiness, that apical pulse rate of 160. It could cause their blood pressure to go up just a little bit, right? They're anxious, they're excited. So is their blood pressure gonna be a little elevated? Probably. But absent wheezes and decreased breath sounds, is that a good thing? No, right? So we heard wheezes first, right? That told us that we still had some air movement, but now that wheeze went away and we have decreased breath sounds. That means it got worse, right? That lung field is now closed off and there is no airflow, right? So that is going to be something that you're going to report to your provider right away, right? We did this albuterol, he got worse, what's next, right? Do we need to add in some chest physiotherapy or like what you wanna do? Cool? Good job to student. All right, you guys wanna take a quick break?